All right, so she said, I'm Jamie Blood. I'm the child and lasting psychiatrist here with UT. I work with CPAN. I work in the clinic as well. Also part of the Texas Youth Suicide and Research, Depression and Suicide Research Network as well, which is a research across the state of Texas. So, all right, so we're going to be talking about handling mental health care crisis in a pediatric primary care setting. Here are our objectives for today. There we go. So we're going to define what a mental health concern is versus an emergency. We're going to talk about the levels of care that there are, and then how to develop a mental health crisis plan in your clinics, and then kind of disseminating information to parents and caregivers as well. So if you do have any questions, you can put it in the chat, or I believe we just hold them for the end, I think. Is that correct, Laura, as far as for questions?
Sounds great. They can put them in the chat. We'll hang on to them at the end, and then they can also ask questions individually at the end.
All right. All right. So what is a mental health emergency? So there has to be evidence of an acute mental illness, and then also evidence of a substantial risk of serious harm to self or others. And we're going to talk more about these specifics here in a couple slides. Risk of harm is imminent unless immediate intervention occurs. Now, imminent meaning it will happen. You have a fairly strong belief that it will happen. Granted, we can't predict the future, so it's just our belief that we feel like it is going to happen if there isn't any intervention currently. That they don't get any intervention immediately. And this is based off of their current behavior, their past behaviors, things they've said, things they've done. So, we're going to take all this to make a decision. All right. So what is a substantial risk of self-harm? So suicidal ideation, not just a passive thought of death, but an actual suicidal ideation, or if it could be a homicidal ideation, although much less rare. They may need some kind of safety intervention for homicidal ideations. Another substantial risk of harm would be extreme physical aggression or agitation. This may be a younger kid thing as opposed to an older teen thing, but that is one of the reasons that could provide enough substantial risk of harm that they might need some kind of safety intervention. If they're unable to administer necessary medications, either the family can't do it, they can't do it for a plethora of reasons. If there's catatonia, which is a severe medical condition that not only is could be from psychiatric, but more commonly actually from a medical condition causing catatonia, especially in the child and adolescent population. It's more common from a medical condition as opposed to a psychiatric condition. Failure to maintain their own safety. It's kind of often one of the obvious ones. If there's a lot of disorientation, that could be a substantial risk because they may do something unintentionally because of their disorientation that could lead to a significant amount of harm. Delusional thinking, which a delusional is a fixed false belief, that could lead them to a substantial risk depending on what the delusion is. Visual and auditory hallucinations. Now, that's something we're going to talk about a little bit more in the future as well, but just because they have them doesn't mean that puts them at risk. It really depends on the nature of them that could lead to risk, okay? So let's kind of break these down more individually. So suicidal ideations, people can mix this up. So you say, oh, they're coming in for SI, but it may not actually be a suicidal ideation. It may be a passive, some people call it passive SI. I prefer to call it passive thoughts of death because there's no suicide thought in there. It's just, some examples are, I wish I could go to sleep and not wake up, or I wish I was never born, or they just think, oh, life would be easier if I wasn't alive anymore. So things like that are this passive, that there's no action, and so they may talk about being a burden to their family. you know, like their family would be better off without them, or I'm too much trouble for y'all. That those are getting there, those passive thoughts of death. And they're usually generalized statements, you know, and you know, if there's no things that they could act on, you know, like no weapons in the home and there's lots of support, then this necessarily isn't emergent. But if they do have a specific plan, they have access to means, whether it's pills, razor blades, guns, whatever, you know, they have access to whatever their plan is. You know, if their plan is hanging and they know where a cord or a rope is, you know, that they have thought about using, you know, that's a more emergent. They have intent. They want to do it. They've thought about a date in which they will do it, or they thought about what it'll take to finally get them there. Those kind of things imply intent, or determining when they're going to do it. Giving away possessions. There's this one teen that I heard about that was like giving away their phone chargers because they weren't going to need them anymore. I don't even think they were a teen. I think they were younger. I think they were a child, so they didn't really have a forethought of like a charger's not important, but to them that was important, and so that kind of deemed like they were giving away their possessions. So that could be a very risky thing for them to do, or something that applies a lot of risk. Writing letters, either there is just saying about goodbye, or apology letters is a frequent thing as well. So those kind of writing a letter to kind of state, basically not in specific terms that they're going to kill themselves or whatever, but they kind of even imply. All right, so it doesn't have to even be like a specific, like concrete plan, but if it is just a plan, whether it's realistic or not, you know, and they feel like they want to do it and they will do it if they are given the chance. So that's kind of what deems it emergent versus non-emergent. Homicidal, kind of along the same lines. They may talk about it. They may have some urges like, oh, I really want to hurt them or kill them, but they've never acted on anything. They've never been an aggressor in the past. They may have some verbal outbursts, but there's not any physical outbursts. And they do have a satisfactory support system. So, but on the other hand, if it could be emergent if they have a plan, they have an intended target, there may be something that they plan on using, or they don't have anybody in their life to give them support, get them the treatment that they need, or supervise them adequately. So that could raise it to a more urgent situation. All right, next would be the aggression or agitation. So if they're just kind of throwing, kicking, hitting at inanimate objects, or throwing the TV remote, their video controller, they're going outside, they're hitting the tree with a stick, you know, inanimate objects. And then they have to be able to de-escalate after a reasonable amount of time. And then they can talk about, or we can't, sometimes if they're young enough, you might want to, I mean, this isn't something we're trying to, don't get me wrong, this is not something we're trying to encourage, but like if they can be restrained, you know, by their provider or their caregiver, not provider, their caregiver or family, you know, that may be enough to mean that it's not urgent because the family or guardian can prevent any aggression. The other side of it is emergent if they're unable to be de-escalated, if they're causing harm to themselves or others, they're lashing out. Animals are an easy target. Sick or elderly population is an easy target, or children. You know, they may not be going after mom and dad, but they may be going after a sibling. They may be going after the family dog. They may be hurting grandma, you know, and sometimes grandparents are the provider. And so, you know, sometimes, you know, I have to have a patient that is a very young kiddo, but he's a very big kiddo, and grandparents are pretty frail, and so they're an easy victim to this kid's aggression. So, it kind of depends on the context as well. All right, for inability to administer necessary medications, the patient's refusing to take those, and the care provider isn't able to get them to do it, whether this is prescription medications or over-the-counter medications, that's kind of the big thing. And there can be a fine line if they're refusing versus inability to actually get them some, and that's a very fine line, that may be very blurred at times when in this situation. They're not taking their daily medications, but even if they have an as needed medication in the moment, they're not taking those. Maybe they have a Risperdal M-Tab or a Cyprexazitis or something like that nature that's a dissolvable or oral disintegrating medication that you can't get them to take. That could kind of go either way because they're not taking, but it can be if it's a life-sustaining medication, insulin, cardiac medications, things that we know would lead them to a life-threatening condition. So that can be a little tricky on this one. Hallucinations. No, just because they have hallucinations doesn't mean that it is an emergency. If they are seeing things that aren't there, they're hearing things that aren't there, that isn't necessarily any emergent. If they're even having a little bit of frustration from it, that it bothers them, annoys them, but it's not necessarily interfering with their life, their ability to function. What escalates is they're becoming agitated because of the internal stimuli. They're getting commands. We call that command auditory hallucinations, or that we get. You may see the abbreviation CAH, on like a report or something like that. So the auditory hallucination is commanding them to do something like kill yourself, hurt yourself, you kill your family, things of that nature, ones I've heard expressed to me. Or the patient is trying to find a place to escape to because they're being tormented by these hallucinations. And in the act of fleeing, they're leaving themselves vulnerable to a dangerous situation. So that's kind of the things I wanted to point out as far as classifying hallucination as emergent and non-emergent. What about delusional thinking? So hallucinations are sensory experiences, auditory, visual, olfactory, tactile. Delusions are a belief, and we call it a fixed false belief is what a delusion is. And the content and context matters, right? If they just believe that there really is an imaginary friend, that's not really hurting anything, right? But if their fixed false belief leads to putting them into a risky situation, that is kind of when it needs to be escalated. If they think they can fly and they're up on the roof and about to jump off, things of that nature, that's really going to put themselves in harm because of this delusional thinking. All right. Catatonia. It's quite rare in child and adolescent. It can be a fatal condition. And so, I know we've kind of all got this picture of catatonia as this waxy flexibility that you've seen portrayed in movies where people get stuck in a certain position. A lot of times that's not it. It is just kind of a rigid posture, or they are so slowed down that they can't function, they can't hardly move, they can't hardly walk, they can't hardly talk. So there's varying degrees of this, but it is in a medical emergency and they need intervention. And to not only help the immediate needs, but also to identify what could be the cause, because in child and adolescent, it is more common that it is a medical condition causing it. But it's pretty rare. I've maybe seen it once or twice, and that was at Children's Hospital in Dallas, where they're a huge hospital system, but it is an emergency. All right, so say that a person does, have suicidal ideations or coming in for safety reasons. How do we know what level of care they need? And so we're going to talk about what the levels of care are. So low acuity is just outpatient care. That's counseling and psychiatry support or counseling and your support. Um, if if there's a non-emergent, family feels like they can keep them safe. Um, there's no plan, there's no intent, there's just kind of these passive thoughts of death. Counseling is and potential medication management would be the best support for them. But raising it up, maybe do they need some kind of more intense treatment that isn't inpatient? So there's that in between. So there's where intensive outpatient programs come into play. We have a couple of those. We have some virtual ones, maybe some in-person ones. I don't believe we have any PHPs in our area. I know there's some in Dallas. I believe Shreveport has one as well. But I don't know if in the Northeast Texas area we have one. But you can always call us to find out what kind of services are available in the area. If you're on the fence, do they really need inpatient or not? And you're not really sure, there are crisis evaluations done through your local behavioral health authority or local mental health authority, depending on what they want to call themselves. And so the parents can call. I think you could even call or your office staff can call to arrange it. But parents can be the ones that call. So maybe they're not emergent now, but if escalates and the parents want to call, they can later. For high acuity, there is intent, there is plan, they need inpatient. Parents can transport them to the facility of their choice. If they need maybe a medical workup first before going to inpatient, maybe that needs to be to the ER, but we don't have to call 911. If maybe the highest acuity would be when there is intent and plan, the child or adolescent says they are going to do it, there are means to do it. Parents either maybe don't have transportation to get them there. They brought them and 3 other kids. So what are they going to do with the 3 other kids? Well, they're trying to get this one kid care. Or maybe on rare occasions, it's, calling them because the parents aren't on board. The parents are just denying that there's a problem, that they can handle it, but you just feel so unsafe that you may need to call 911 and have the police get involved and have some other form of transportation arranged. They may need to be put on an emergency detention, which is what the police can put them on for them to be involuntarily hospitalized. Is pretty rare in child because most parents want the best for their kids, and if multiple people are telling them, hey, they need hospitalization, most of the time they end up complying, even if they initially didn't at first. So those are the different kind of levels of care that you need to be thinking about. So are there ways that you can screen for it? So you may do this at every well check. If the chief complaint coming in today is suicide or agitation or behavioral problems, these would be the times to use some of these screening tools. And those are kind of the 3 most commonly asked, which is the suicide screening questionnaire, the Columbia suicide rating scale, and then there's a question built into the PHQ-9. So here's the scales. If you can even see them on your computer screen, it seems pretty small, unless maybe you have a bigger monitor. But those are kind of what they look like, and we can provide these for you if you don't already have them. Okay, so these are just some common examples that are easy to use. Okay, but once again, these are just screening tools. Screening tools are just a part of your assessment. You still have to do your part. If they have a high score, does that mean you have to be hospitalized? Not necessarily. Maybe that may lead to a higher risk, and that's something you need to factor in. But sometimes they can over exaggerate or even under exaggerate on these screening tools. So it's going to be your clinical interview, the one-on-one conversation. that you want to have with the patient. And you do want to have it a one-on-one. You want to have the parents step out, and then you may want to talk to the parents alone too, if you have staff or someone that can, be there with the child while you're in the room with the parents. So it also has to be age appropriate. If we're talking about an 8-year-old, are they going to have the full understanding that, what suicide even means? So, and then there's some very intelligent 8-year-olds, and then there's some that are maybe more developmentally delayed that may have no clue, so it's really, you need to use your clinical judgment after you've done your thing. So, what kind of things do you ask? And you have to be very direct and straightforward. You don't want to ask kind of side questions or leading questions. You want to be very specific. Are you currently having thoughts that you would be better off dead, or that you want to hurt yourself? Do you have thoughts of killing yourself? And we've tried to debunk the myth that asking about suicide leads to suicidal thoughts. It does not. You are not going to implant something into their minds if you just ask them if they're suicidal. That's not the case. Research has showed that. So you want to ask about if they have a plan. If they say yes, they've been having thoughts about killing themselves, have you thought about how you're going to do it? Have you come up with a way to do that? Like I said, you've got to be very direct. And then you always want to ask, have you ever done anything to try to kill yourself or hurt yourself in the past, to see if they've kind of crossed that threshold once before, because that puts them at an even higher risk for completion if they've had a previous attempt. So asking about previous attempts or even self-harm. Even if it's non-suicidal self-injury, also increases that risk of suicide completion. Asking if they have access to anything. Do you have pills that are just left out on the counter? Are knives and sharps locked up? Do you know where your parents keep razor blades? Are there any weapons in the home, guns, knives, things like that they could easily hurt themselves with? And then you also want to ask about substance use. Concurrent substance use, depending on what it is, may lower their threshold to acting on these thoughts. So it is important to, while you're at it, ask about substance use as well. That could be them self-medicating, or it could be contributing to the picture. So that's also important. So that's the patient. Let's talk about the parent. You want to talk to them privately. Like I said, you want to do one-on-one with each. And you want to ask what changes have you noticed, either in the home or in school, at church? What kind of talk have they been? Have they been talking negative about themselves, like I'm a loser, I'm useless, I'm worthless, nobody likes me, everyone hates me, those kind of things. And then you want to ask if the parents know if there's been any prior suicide attempts or self-injurious behavior. Maybe the child didn't want to tell you about it. And then access to any weapons or other things like pills, knives, sharps, anything else that can be a potential lethal means of killing themselves. And then also a family history of attempts or completed suicide and risk, because that shows that there's an increased risk for suicide attempts and completions if there's a family member. Let's see. You may want to ask if they previously been, if they're pretty new to you. You may ask, hey, have they been in a psychiatric hospital before, and stuff like that, or what all have they been diagnosed with in the past? If they're relatively new to you, or you just don't have a lot of information because they come and see you every couple of years, All right. So what do we do about a plan? So here's. I modified this one to kind of fit more of a pediatric population. And so this is my modification, and you're all welcome to use this. So you do want to post this template in a visible, easily accessible area of the staff, So first one is, if a patient presents with suicidal ideations or their suicide ideations are suspected or detected with screening questionnaires. who should be called or alerted to assist with the suicide risk assessment. So you need to have who's going to do this. Is it going to be the physician if it's a screening tool, and the MA or whoever does those screening tools? Who are they going to alert once those are done? Is it going to be, is there somebody in your office who's going to be lead on that? Whether it's the nurse or maybe somebody with some kind of mental health background. So you write down who it is, and like the next one is just who should be called to assist in the collaborative safety planning. You know, who in your office is going to be doing these things, just so that there's a specific plan, and treat this plan as if this was a medical emergency as well. So you know, it's an emergency regardless whether it's a mental health or a medical condition. You need to have these protocols in place so that the staff know what to do and who to contact, who's in charge. It's kind of like that whole go call 911. When you're in a crowd, you don't just say somebody call 911. You point to somebody and you say, you go call 911. So it does need to be very specific. If the patient does require a hospitalization, if they've met that high acuity, what are in the area? So these are some hospitals that you can list their names and phone numbers. And that is something that we can provide when you're filling this out. We can help locate some of these places. And then who's going to maybe help facilitate them? You may want to have a staff at least call a hospital, like, hey, do y'all even have beds? You know, do y'all take these kids? Do we need to get medical clearance? And most of the time, no, you do not need medical clearance in the child and adolescent population. There's only a few times that you really need medical clearance, is if they've attempted recently, or if there's been recent drug or alcohol use, is what they told me. I called a couple of facilities, and that's specifically from there. I said most of the time, we don't need a medical clearance. So there's no point in just sending them to one extra step. And we all know that the ER is a long, tedious process. If they could just go directly there, it's going to be less burden on the patient and the family. And they're also not getting an ER bill on top of a hospital bill. So save them the time, save them the money. Most of the time they can go directly there. But if they do need medical clearance, you want to document which hospital we're going to send them. You know, if they're here in the Tyler area, we got a couple choices. But if you're more rural, you may only have one choice. So, you know, just so your staff is already knows where and who and their phone number and stuff like that. Or who's going to help get them there? Is the family going to transport them? Do we need EMS to transport them? So, you know, what level of care do they really need? And then what about once the patient has left your clinic? Who's going to make sure? You want somebody to call the family to make sure that they actually got there, that they arrived, that they didn't change their mind. And then you also, who's going to schedule them a follow-up in 1 to 2 weeks after discharge, just to make sure that they're not having side effects from the medication, because maybe they were only in the hospital for a couple of days, they were started a new medication and they didn't develop a side effect until, you know, a week later. You know, you want to just make sure that their medications they may not be working effectively yet, because we know it takes weeks for some of these medications to work, but at least they're not having any side effects, and that they have enough refills, or whatever, you know. So you want to schedule them. So that's just kind of a basic protocol for your office. Like I said, you want this in a visible area. I made it with the red circle, you know, so that people can see it, and you got very clear and precise on what and who is doing what specific task. And so this is just an example of one. Here's a safety plan template. This is if you're not staying in the hospital, they're okay for outpatient treatment, then you want to, they can fill this out. This could be something that you want them to complete before they leave your office. What are the warning signs? Like, what do we typically know leads them down the path to suicidal thinking? Is it, you know, whatever it is for their situation? Fill out 1, 2, 3. What are some internal coping strategies that they can do to take their mind off? Relaxation, coloring, listening to music, going, you know, those kind of things. And this is once again something that CPAN can help explain more in depth if you need more. What people in social settings can provide distraction. Is there a favorite aunt or uncle or grandparent that can really help them, when they're feeling down and sad? Is there a specific thing that they like to do, like going for a walk or going to the gym, going playing a sport, going for a hike, whatever is reasonable. So some options. And then who can they ask for help? Is like kind of all maybe the same person that's up here on step 3. It could be grandma, it could be aunt or uncle, it could be your church pastor. Hopefully they have a counselor. That may be someone here, but there's this place for them down here as well. So just a friend, maybe they have a close friend that knows what they're struggling with. An older sibling, anyone can really be put in these places that can help support them. If they have a clinician, a psychologist, an LPC, whoever. If they have a psychiatrist, that needs to be on here. And then some what the family can do if they if they can't bring them to your office or they don't need to be brought to your office, like what urgent care services, of course, and then the suicide prevention line can easily be called as well. And then making the environment safe. This is more for the family, making sure that pills and sharps are locked up, firearms are locked up, so they don't have access to those things. And then, that maybe include like, they have a daily pill, that weekly one, so they only have so many pills out, and helps them remember them taking their pills more frequently, so that may be something as well. This is just one example. Oh, and there's some of these are longer than one page, and it can have like reasons for living, where it's kind of maps out their goals and their future orientation, so they can remember like, oh, this is what I want out of my life. So here's just another one. Like I said, these are all just examples. Considerations for your office. Where is this something to put? How many entrance exits? How many staff are we going to actually have available at any given moment? Quick tick access. Do we need to know where our translation services are going to come from? Stuff like that. So these are just some things that you need to consider as well. Training, we recommend that you do this annually, but even quarterly would be better, of course, for any of these staff trainings. Include this, like, hey, this is where it's located. Is all the information on this safety on the office template, is that all correct? If the staff changed, have they changed roles? Maybe that's not the right person anymore. So making sure that that's all up to date. And then maybe the staff could benefit from some type of training in mental health that would be specific to your clinic, so that all these things kind of are available. Documenting, we all know by now that you have to document everything you do in medicine. So just be cautious. You documentation, what you did, so that if it ever comes back, it's in the documentation. All right, what about action steps? So once they've been determined that they're at risk, what do you do? So you don't ever leave them alone. You want to be able to call somebody in their room, whether that's your nurse, an MA, maybe even just an office staff, just to sit there while you're trying to figure things out. If say they're brought in by aunt or grandpa, are they the decision maker? You may need to step out to call the legal guardian. Sometimes you may need to call 911. Just these are the things that you really need to do. And that's why if you have it all written out, it'll be easy to follow, and it'll make your life much easier. We kind of talked about I talked about this previously, but do they need to get medical clearance? Most of the time, no. If they've had a suicide attempt, that wouldn't a workup, like they had a toxic ingestion, they've had some deep cuts, they tried hanging themselves, they may have passed out, or if they've had recent intoxication, not just they took a couple puffs from a vape pen, that's not really going to affect anything, but intoxication. All right. How do we talk to parents and patients? Here's some strategies for helping start the conversation. I'd like to speak to you about something that came up in today's visit. Your child has expressed blank, that they've been having thoughts of suicide for the past couple of weeks or couple of months. They're higher risk because of Uncle Charlie who died by suicide, because they've cut in the past, because of whatever that could have puts them at a higher risk. And you're supposed to, I'm very concerned about your child's safety, given this discussion. This really does need immediate attention. We want to make sure that your child is safe and healthy. We want the best for them. And that may require taking them to the emergency department, may require taking them to the psychiatric hospital. So, or we're going to call the crisis evaluation line to see what they think. So we're just kind of being straightforward and with them. What about confidentiality? So we have to inform, our duty is to inform if there is a relative risk. So if they've made references to suicide, or they've talked about suicide, we want to tell them, but you don't have to disclose why. So maybe it's because parents are going through an ugly divorce, or if their sexual orientation or whatever reason, we don't have to tell them why they're suicidal, but just that they are. So that is something that confidentiality does not cover, is that we cannot not tell the parents that they're suicidal. So that's something we do need to do. What about if the parent refuses to act? Provider may be duty bound to report the incidents. We can call the Department of Family and Protective Services. If you don't feel like, I guess there's kind of like really two levels of this. It's either calling 911 and getting, the police involved, or calling Family and Protective Services because you don't feel like the family is taking it serious enough. So, it'd be necessary to report, to call and report as of reporting online, just because the online one, I think they have 72 hours instead of like 24 hours they do for phone calls. So you may need to call instead of just doing the online one as well, because of the response time they're required by the state. All right. Resources. So I've mentioned these before. The local mental health authority or the local behavioral health authority, that's kind of the same thing, just some people label it different. And then some of these places have a mobile crisis outreach team, MCOT for short. So all counties have them, and then they employ different people, like a qualified mental health professional or a licensed mental health professional. Those are some that go and do assessments. Like in my county, Smith County, Andrews Center does that, and they have a crisis assessment team that does that. And there is virtual options. I don't know if they're doing in person or not. I've seen most of it's been virtual. So the MCOTs are the community workers that complete these crisis risk assessments, and then they'll recommend what level of care that they need. And then if there needs to be some kind of how they're going to go about doing it. So this is a resource to providers. If we're not sure if they need it or not, we may want to call the MCOT team to let them help you make that decision. All right. So we broke it down by regions for you. Give this up for a minute so you can kind of look at yours and make sure your areas served. And if you want to take a picture, and we can always provide this information to you later, so don't feel rushed to write it down or take a picture of it or anything like that. But these are the ones that are kind of the region that we're in right now. And then these are support lines. You know, we got the national hotline. You don't have to remember the whole 10-digit number anymore. Now it's 988. There's a texting line as well. There's specific ones for LGBTQ. And so you can make sure the patients know these crisis lines, make sure your staff know to give them out. So these are options as well for resources for you. As we know, it's switched over to the 3-digit one. That was replaced like I said, the 10-digit one. It's all funded by the U.S. government, and they have 180 local crisis centers that are taking those calls. So it's 24 hours, 7 days a week across the United States. So just makes it an easy way for them that the teen can call, or the child or adolescent can call or text. So it's a great resource for the family to know. All right, how can we help? So, you know, you can call our services and we can help give you examples of these safety protocols. You know, if you're going to call, we're going to talk about, is this an emergency or not? But if it's not an emergency, then we can kind of go through, what do you need? You know, do you have safety plans? Do you have these office safety protocols? You know, do you have these numbers? We can help provide some of those things, but we can't provide crisis services. That's what the MCOT for, or any other services that you may want. So we can just help get you those things. What about if you want some further learning on your own? Here is some, excuse me, I think I'm losing my voice. Some resources for further learning. Mental health first aid, and there's a youth one specifically. There's applied suicide intervention skills training, question, persuade, refer, and these are all things that we can provide you. And so in recognizing and responding to suicidal risk, safety side, primary care. So these are all things for just further learning. And these are resources that we can help provide, the screening tools and templates. So that's what CPAN/PeriPAN can help provide. Resources that we got these from, and resources you may be able to use. The CDC has some mental health flyers that you might want interested, that are patient specific, that you can put up in your office to help kids know, you know, help families know what are the warning signs and such. So that is something that we've recently talked about, maybe trying to put together, is some flyers or something that you have to help educate families on what are the signs and symptoms of depression, of suicide risk, things like that. So that is something that's going to be in the works going forward. All right. That was the end of my presentation. Let me stop sharing so we can open it up.
Thank you, Dr. Blood. Would love to open this up to questions. That's an excellent presentation, receiving lots of good feedback. But as providers out in the community, we would like to have your questions. How can we help you? How can we support you in the community with your primary care practices? What questions do you have for Dr. Blood? And please feel free to unmute yourself. Question: in Texas, do you 16 to 17 have any particular legal privileges? Are you able to read that, Dr. Blood?
I am. Let me read it again.
Okay.
You know, that's a good question. I'm not sure what the age line is. I don't think there is. Up to 18 parents are still the consenter for any medical and psychiatric behavioral health care. So I don't believe so. We do want assent from the child, but we don't need their consent, if that makes sense. Because we just getting them on board is going to help in the treatment anyways. They have them wanting help and them understanding why it's important. But it's just kids do not provide consent. Even as far as I know, it's up to until they're 18.
Great question. What other questions do we have? We still have about 10 minutes. Dr. Azuma.
Yes, in the state of Texas, 17-year-olds are deemed to be consenting. They can consent, they can give consent to or for treatment.
Thank you, Dr. Moon, for clarifying. Is that just outpatient, or does that include hospitalization in a psychiatric facility as well?
I just know they can consent for treatment.
Okay.
Like you pointed out, we always need assent and consent from parents. But 17-year-olds can consent in the state of Texas, the way I understand it.
All right. Dr. Moon would know best. He was the working inpatient when we had our inpatient facility. So thank you, Dr. Uduma.
The payment issue is a different one.
Yeah.
You know, when we're talking about the consent for treatment, but then you also take into account who pays for treatment.
Yeah, that is a good question. You know, sometimes if they're unfunded, that's when you want to go through these local mental health authorities to see if they have funding for that treatment. It's harder to get in the kid world because of the lack of inpatient beds, but there is funding out there for it.
There are a couple more questions in the chat, Dr. Blood. One from Dr. Powell first, and then Dr. Davis.
All right. Is Prozac still the best to start with? Best, I'm not sure that there is a best. You know, it is a good one, yes, if for the treatment of major depressive disorder, generalized anxiety disorder, and a few other mental health conditions. So there's definitely a reasonable one to start with. We use them all. So you may want to ask, you know, is somebody else in the family's on an antidepressant to see if they've had good success with it, since they're going to be, you know, sharing some bit of genetics with them. And then Dr. Davis asked, do we have many facilities who are equipped for managing mental health crisis in autistic kids and teens, especially in terms of how therapies are provided? The facilities, you know, most of them, as long as the child is self-sufficient in eating and hygiene, and they're not considered mental retardation below the 70 IQ, I believe they still take them. So it's not necessarily about autism. It's more about their developmental functioning and self-care. Now there is, I know Brentwood reached out to me recently, and they are making a younger autistic unit. I want to say they would go down to 4 years old. That they are making more of an autistic specific unit. I don't know if that was intended to be a younger autistic or just autism in general. But autism doesn't necessarily mean that they need to be on their own special unit. You know, most of them, if they're well enough functioning, you know, can still benefit from the same types of things. Hopefully that answered your question.
What other questions do we have? So while we wait for other questions, I just want to mention, I did put this in the chat. I know there are some folks who are on with their cell phones. So I did want to mention that if you are in a clinic that has either an older crisis plan or you do not have a crisis plan in place for your clinic, please reach out to your CPAN team. We have very skilled professionals here, mental health professionals, that will help you develop an individualized crisis plan for your clinic, similar to what Dr. Blood had and shown, but very, very specific, so that when a crisis happens, not if, because it will, when a crisis happens, everybody is fully aware of what their role is in that. So, question about MCOT, Dr. Blood.
All right, so what tells more about MCOT? So it's a mobile crisis outreach team. So they are the ones that are, I've seen varying degrees of what they do in person versus virtual. During pandemic time, it was all virtual. I think they've done some in-person options now, but a lot of times it's still virtual, where they do a crisis assessment to see if they need hospitalization or not. So if you're the one calling them and not the family, then you need to make sure you have a good contact for this family, so that they can get a hold of this family. But I think they highly encourage the family to call so that they already have that person on the line who needs the assessment done, and we get all their information from them. So it may depend on time of day, may depend on staffing, as whether it's going to be virtual, in person, location, if they're so.
One of the things that each LMHA or LBHA is very different as far as if they have a mobile team. Even during COVID, the mobile teams weren't mobile anymore. And so each one is slightly different. If you want more information about MCOTs for your region, it varies from county to county. Please feel free to reach out to your CPAN team. That's information that they should have right at their fingertips.
I think I have a link somewhere in my notes section.
You know
for
what,
the
Dr. Blood?
website.
We can get that sent off to Dr. Powell.
Yeah. I will find that link real quick. It's in one of my notes under one slide, but I don't remember what slide it's under.
What other questions? We have about 4 more minutes. Dr. Powell, do we have your email address in our information? Okay, thank you. We'll get that sent to you. Dr. Powell, when you say any psychology urgent, tell me more what you're looking for with that question.
Let me. Sorry, Dr. Powell, 15-year-old suicidal kid is. Did I miss something? Or maybe after this, we can reach out to Dr. Powell to see if there is a specific need.
Let's reach out to her.
Okay.
Yeah, CPAN can get you counseling right away, Dr. Powell. We just need to go ahead and get that information from you. You can have your support staff reach out to us. They can either text us or call us. Yep, give us a call. The team is waiting for your call right now. They're actually on this call, so they'll expect it. And Michelle, we can get those things to you. That's not a problem. All right. Anybody else with questions the last couple minutes? All right. I think we'll go ahead and call it. Thank you so much for your time today. We're so glad you joined us. We will stay on for a couple more minutes in case you have any other questions. Dr. Blood and I'll just hang out here. Thank you so much for joining us. We will be having another session in October. Watch for the continuing education invitation for that. Have any questions about today's session, please do reach out to your CPAN team. Excuse me. And we welcome the opportunity to support you. Have a great day.